Hello, everyone. My name's Ryan Nichols. I'm a second year resident at the University of Utah, and I appreciate the opportunity to engage with you guys today in one of these lectures. And I just wanted to take the opportunity to chat a little bit more about syncope. We're kind of going to go over basic pathophysiology, some epidemiology, common causes of syncope, our basic workup, basic treatment algorithms, and then final disposition planning. So really, what is syncope and how common is it? So syncope is defined as a loss of consciousness and inability to maintain postural tone with quick return of consciousness. Uh, this makes up about 1 to 2% of US ED visits, but about 6% of admissions. And importantly, as we walk through this a little bit further, near syncope or pre-syncope, which can be a feeling of flushness or lightheadedness or premonition that one is going to lose consciousness, carries the same pathophysiology and risk as syncope. So when we're working up a patient for syncope, it also makes sense to pay attention to patients that are prescribed or describing any of these prodromal symptoms but don't have full loss of consciousness. So looking at the actual underlying pathophysiology of this disease process, it really only takes about 10 seconds of lack of cerebral blood flow or nutrient supply, or a 35 to 50% reduction in cerebral perfusion in order to cause syncope. And oftentimes this is secondary to decreased cardiac output, so either loss of vascular tone or bradycardia. But vasospasm, especially in the cerebral blood supply, can also cause syncope. So that's something to keep in mind. And really, it's a reflexive mechanism because moving to the supine position allows for greater perfusion to the brain via gravity. And so this can be helpful in restoring consciousness, but also return of a perfusing rhythm or kind of coming back online of the autonomic nervous system can also help improve or rather restore consciousness in the setting of syncope. So really, what are our main causes here? Walking down from kind of most common to least common, at least of the ones that we're able to identify. So vasovagal or reflex-mediated syncope occurs about 20-21% of the time. Cardiac syncope is about 10%. Orthostatic syncope, 9%. Medication-induced syncope is about 7%, with the neurological cause causing about 4%. And then despite our best efforts and a thorough workup, almost about 40% of the time we get to a place where we don't have a great answer in terms of what caused the patient's syncope. And then there's also kind of a psychiatric component, and looking through the resources, there's not really a great definition of how often this occurs, but in certain populations, it's definitely something to think about, though very much a diagnosis of exclusion rather than the first one that we're going to lean towards. So speaking about these specific causes a little bit more fully, vasovagal or reflex-mediated syncope really doesn't have any increased risk of death compared to a non-syncope population. And this is secondary to bradycardia or vasodilation in the setting of decreased adrenergic tone. And this is the patient that's saying, yeah, I felt really lightheaded, I felt warm, my vision started to tunnel, I felt a little bit sweaty, and really had some prodrome symptoms, and then had a loss of consciousness. And oftentimes this is in the setting of an unexpected or unpleasant sight or sound. So exposure to blood, a very emotional situation. And this can also happen if you've been kind of standing or kneeling for long periods of time, when one is urinating, when one's moving one's bowels, coughing or swallowing. So really identifying the kind of triggers up into the moment of when the person had syncope can be really helpful in this. And carotid sinus hypersensitivity is also a cause of reflex-mediated or vasovagal syncope. And this can be with turning one's head or combing one's hair and kind of manipulation of the neck itself. This is oftentimes in the setting of kind of cardiovascular disease, heart disease, vascular disease. So beware of underlying health issues as well if this is something that you're considering. But the vast majority of the time, vasovagal or reflex-mediated syncope will be will be more of a benign cause of syncope than some of our other causes here. Moving on to cardiac syncope, this carries about a two times increased risk of death compared to the non-syncope population. And when we look out about 6 months from the precipitating event, their all-cause mortality is at or a little bit greater than 10%. So this is definitely something to pay attention to. Oftentimes, cardiac syncope will present without a prodrome. So if somebody says, yeah, I was walking along and then I lost consciousness and I woke up and I wasn't quite sure where I was, and you've kind of taken a thorough history, they don't have a history of seizures, that's not something you're suspecting, really be thoughtful about a cardiac mediated etiology. And this can really be broken down into two pieces. One is structural causes and the other is dysrhythmias. So when we think about structural causes, we think about aortic stenosis. So this is an elderly individual that felt short of breath, was exerting themselves, walking upstairs, and then had a sudden loss of consciousness. Pulmonary embolism can also present with syncope. So be thoughtful in the individuals that are coming in with either high well score or you have a clinical suspicion of venous thromboembolism in the setting of syncope, because PE can definitely cause this. Hypertrophic cardiomyopathy can also be an underlying precipitant, especially in young athletes. And then myocardial infarction can also cause syncope as well. Moving on to dysrhythmias, there's kind of a whole gamut that can cause syncope, but both tachy and bradyate dysrhythmias can cause loss of consciousness. AV block, prolonged or shortened QTC, Brugada syndrome, Wolff-Parkinson-White, or arrhythmogenic right ventricular dysplasia can all be causes of syncope. And so a really structured and really thorough review of your EKG when you're evaluating a patient with syncope can be really helpful. Some of our colleagues and some of the FOAMed literature and even MRAP have been talking about just having a EKG syncope macro that you walk through every time you've got a person coming in with syncope, so you make sure you're evaluating for all of these dangerous etiologies and making sure you're doing a really thorough assessment to exclude any of these. Kind of moving on from cardiac, orthostatic hypotension or orthostasis can also be a cause of syncope, and usually this occurs within 3 minutes of moving from one position to the other, though it can occur later than that. And this is secondary secondary to the inability of the autonomic nervous systems to maintain appropriate vascular tone. And this can be in the setting of kind of advanced disease processes with autonomic neuropathies. So advanced diabetes, Parkinson's disease, amyloid, but also in the setting of hypovolemia. And when we're doing orthostatic vital signs, the definition of orthostasis is a drop in systolic blood pressure greater than 20 millimeters of mercury, or a drop in the diastolic blood pressure greater than 10 millimeters of mercury. And this is 3 minutes after postural change, so moving from either lying to sitting or sitting to standing. The thing to pay attention to, though, is that about 40% of individuals greater than 70 years old will be orthostatic and asymptomatic, and about 25% of individuals less than 60 will also be orthostatic and asymptomatic. So orthostatic vital signs aren't something you can hang your hat on, but if you've got a really good history for significant volume losses or poor PO intake, and you've got somebody who's endorsing a syncopal event and they look dry and you've got orthostatic vital signs, then I think you've got some good information. But it's definitely something to consider that you can still be orthostatic, especially at advanced ages, and not necessarily be symptomatic. Moving on from there, medications can also be a cause of syncope, and they are the most common contributor to orthostatic syncope. And really, when reviewing a medication list, this can be incredibly helpful in the evaluation of the syncope patient, but make sure you're paying attention to beta blockers, calcium channel blockers, anything that's going to prevent them from either increasing their vascular tone or increasing their heart rate to compensate for changes in position. And then also pay attention to diuretics or arrhythmogenic medications, because these could be leading to hypovolemia or arrhythmias. And then, especially in the evaluation of the elderly patient, just polypharmacy as well is something to pay attention to. Moving on from there, neurological causes of syncope are more rare than others, but they do increase your risk of death by about 50% compared to the non-syncope population. So they're definitely something we want to make sure that we're evaluating for. And this is defined by a transient loss of consciousness without sustained neurological deficits. And really, true syncope secondary to a neurological cause is separate from TIA, CVA, or seizures. And sometimes one of the hardest things to do in these patients is to figure out, did this patient syncopize or did this patient have a seizure? So if you've got somebody that's coming in that had a history of observed kind of rhythmic or abnormal muscular movements that were stereotypical for either tonic-clonic episodes or fluttering of the eyes or a focal neurological deficit, or they had a postictal period, or they bit their tongue, or they lost urinary continence. That kind of pushes you more into, I suspect this may have been a seizure episode. But if you've got somebody coming in that either had a great prodrome for one of these other causes of syncope, or really doesn't have any of those stereotypical movements, then you're probably more in the syncope category. But more returning to this neurological causes, a couple of these causes for neurological syncope can either be subclavian steal, which is a more rare diagnosis, so narrowing of the arterial blood supply proximal to the subclavian artery, so that exertion of the limb, often the left limb, causes an increased demand for blood flow, and you have reduced cerebral perfusion because of that. Or subarachnoid hemorrhage. This is definitely something you want to be paying attention to because of either the rupture of this aneurysm or associated vasospasm. So making sure you're being thoughtful about, is there a headache, is there neck stiffness, is there vomiting, does this person have a risk factor for aneurysms? When you're evaluating syncope can be incredibly helpful. And then moving on to psychiatric, again, this is a diagnosis of exclusion, but about 62% of patients with unexplained syncope will have associated underlying mental health diagnoses, the most common of these being generalized anxiety disorder or depression. And hyperventilation can be an underlying cause of syncope due to hypocarbia. And patients that you can pay attention to this in is young patients with multiple episodes of syncope, different types of prodromal symptoms, and really a thorough workup that excludes any underlying cardiac causes. You have a low clinical suspicion for seizures. You don't suspect medications are at play or substances. And again, this is a diagnosis of exclusion, but definitely something to keep in the back of your mind. So moving on from causes to our evaluation in the emergency department, this is where a thorough history can be incredibly helpful and really guide the rest of our workup. The physical exam is also helpful, kind of in a more guided fashion, but really paying attention to your history into the preceding symptoms. So what is the environment just prior to the patient having the syncopal event? Were they having chest pains? Were they having palpitations? Did they have an excruciating headache that came on? Are they endorsing any back or abdominal pain? Have they had any significant fluid losses recently? Did they just travel on a plane or have recent surgeries or have risk factors for venous thromboembolism? So making sure you're taking a detailed history can be incredibly important in these patients. And then also maintaining a high clinical suspicion for single vehicle motor vehicle collisions. Oftentimes syncope or loss of consciousness can be the driving factor for this collision. And so paying attention to these patients for medical causes in addition to traumatic injuries can be incredibly helpful. Then moving on to our physical exam. So doing a really good cardiac exam to evaluate for new onset murmurs or an irregular heart rate, looking for signs of bruising or trauma, listening for bruits if indicated. Rectal examination with a guaiac test can be helpful in patients that you're concerned for possible occult GI bleed. All of these can be very helpful and again are guided by your history. And then moving on from there in terms of kind of adjuncts to our workup, every patient that comes in with syncope warrants an EKG, and this is a class 1A recommendation from the American Heart Association. The American Heart Association also recommends orthostatic vital signs, which can be very helpful. But again, remember that in patients over 70 years old, upwards of 40% of these can have orthostatic vital signs and be asymptomatic. So don't hang your hat on orthostasis if you've got a suspicion for some other underlying cause as well. And then moving forward from there, if you're concerned about significant blood loss or anemia, CBC can be helpful. If you're worried about metabolic derangements, BMP can be helpful. In patients of childbearing age, making sure to evaluate with a urine pregnancy test uh, for possible underlying ectopic. Um, so really having your laboratory workup guided by your history and physical examination can be incredibly helpful. And we'll get into this a little bit further, but there's not recommendations for a broad-based reflexive laboratory workup that's irrespective of the clinical situation. So really making sure you're doing a laboratory workup that is in line with your clinical suspicion and not something that's just firing off a lot of labs is going to be really important. So moving on, what else can we bring to the table to help aid our clinical decision making in the setting of syncope? So there's a whole number of clinical aids that exist. MD Calc can be a great resource for this. There's the San Francisco syncope rule, there's the Boston syncope rule, there's a couple other clinical tools that are out there. The San Francisco syncope rule is probably the most well known and can be helpful. The benefits of these tools are that they have a very high sensitivity for picking up patients that are at risk for bad outcomes or have high risk factors. The drawbacks of these tools are that they have pretty poor specificity, and at least regarding the San Francisco syncope rule, they had the kind of follow-on studies to replicate their initial high sensitivities failed to show that same level of sensitivity. So knowing that they exist and using them as adjuncts can be incredibly helpful. But I think clinical gestalt can also bring a lot to the table in this. And really, when we're thinking about patients with syncope, looking at all these rules and looking at kind of the high risk factors throughout all these disease processes, if you've got elderly individuals, if you've got a history of structural heart disease, if you've got a crit less than 30, systolic blood pressure less than 90, an abnormal EKG, or a family history of sudden death, these are patients that I'd be more concerned about and would probably be more conservative in my workup and disposition rather than ones that lack these risk factors. So what about kids that come in with syncope? As with most things for kids, the vast majority of these cases are benign, but again, our job is to rule out concerning pathology. And looking at the pediatric population, about 80% of kids presenting with syncope will have a vasovagal episode. 10% will have a neurological cause, which in these studies, seizure was included in this category. And then 2 to 3% will have a cardiac cause. And when thinking about concerning risk factors in a pediatric population, they're the same ones that we spoke about just previously with adults. But I'd also include here age less than 6 and occurrence in syncope in the recumbent position or when the patient is lying down, or if they're having recurrent episodes of syncope, or if they're having prolonged loss of consciousness, those would also be concerning risk factors. In 2017, the American Heart Association, in association with some other, I believe the Heart Rhythm Society, put out a set of guidelines related to the workup and management of syncope, and this has been endorsed by the American College of Emergency Physicians. They don't have their own specific policy statement, but do endorse this one. And going through their policy paper here, I pulled out some of their different targeted recommendations. This is not a comprehensive list of what they recommend, but at least related to us in the emergency department, these are some of the things that I felt were very important. So their class 1 recommendations are to obtain a thorough history and physical, which, like we talked about, can be incredibly important in guiding your workup. They share that an EKG and orthostatic vital signs are indicated in all patients presenting with syncope. And then they also recommend assessing for key short-term and long-term risk factors, which we should be doing in all patients, but especially in these patients with syncope. Moving on to their class 2A recommendations, they share that targeted blood tests are indicated, but as we get down to this kind of class 3 recommendation as well, they share there's no benefit to reflex broad spectrum laboratory workup. So allowing your laboratory workup to be guided by your clinical suspicion will serve you well in this. Then moving back to class 2A recommendations, they also share that a structured observation and workup algorithm can reduce admissions without increased risk. Here at the University of Utah, we don't have a structured algorithm just yet, but I think that would be something to keep in mind, and I'd be curious to hear what you all have in Vietnam as well. And then in the absence of high risk factors, they share that syncope can be managed as an outpatient. And if you've got concern for structural heart disease, such as aortic stenosis, a TTE can be incredibly helpful in further evaluating for this etiology. Moving down to Class 2B recommendations, they share that the use of risk stratification tools, or these clinical decision aids that we just spoke about, can be helpful to identify at-risk populations. And they also share that unless you're concerned about MI, a troponin really isn't going to help guide your decision-making much. And then down to these Class 3 recommendations that share there's either no benefit and no harm. They don't recommend a reflexive broad spectrum laboratory workup. They don't recommend CT or MRI in the setting where somebody's fully neurointact and does not have recent head trauma. Now, if you're concerned about these, they're definitely indicated, but in the asymptomatic patient, they're unlikely to guide further workup. And then they also share if you do not have a clinical suspicion for seizures, an EEG really isn't going to help you much at this point in time. So what do we do with these patients, and where do they go? So if you've got a patient with significant risk factors, or you suspect a cardiac or a neurological cause of their syncope, these are patients that likely need to come into the hospital for further monitoring and evaluation. But if you've got a really great story for either vasovagal syncope, medication-induced syncope, or orthostatic syncope, and you've been able to address those causes. So with the vasovagal syncope, you've been able to provide kind of good education regarding what can cause this again in the future. If you suspect medications are at play and it's safe to do so, discontinuing those medications for a short period of time, or providing alternative medications, or in orthostatic cases, providing oral fluid repletion, or if needed, IV fluids to address these, and you've been able to reverse those causes, these patients can likely be managed in an outpatient setting. Kind of down below this slide here is a table taken from the guidelines from the American Heart Association, and this is just kind of a discussion of concerning causes of syncope that they would recommend admission and further evaluation for. And so you can see here, these are symptomatic arrhythmias. These are significant causes of either cardiac ischemia or structural heart disease, or significant blood loss, significant trauma, or persistent vital signs despite resuscitation. These patients all probably warrant admission. And really kind of being thoughtful about our treatment of these different causes. Again, it's really respective of what the underlying etiology is here. So if you've got an individual that's coming in with a cardiac cause of syncope, there's, I think, further observation and admission is probably going to be our best plan. If we've got a medication that's playing into arrhythmia, is probably pulling that off, but they probably need to be monitored for a longer period of time. If somebody's coming in with vasovagal syncope, I think providing really strict education and precautions around what may cause this, again, can be incredibly helpful. If somebody's orthostatic, making sure that we're assessing for hemorrhage and repleting their volume. And then getting into these neurological causes, if somebody's coming in with subclavian steel or subarachnoid hemorrhage, they definitely need further treatment and evaluation. So most of this information comes from Tintinelli's chapter on syncope, but this also is based in part of review on the 2017 American Heart Association guideline for evaluation and management of patients with syncope. And I definitely appreciate your guys' time, and look forward to the conversation with you all as well.